afternoon, everyone, and welcome to today's webinar hosted by Region 10 chapters of HFMA. The topic for today's webinar is "The Patient is the New Payer, Positioning Your Revenue Cycle for Successful Patient Financial Engagement." Before we get started, I would like to review a few housekeeping notes. All phone lines are on mute to avoid interruptions during the broadcast. In your audio panel, you may select to listen to this broadcast using your computer's mic and speakers, or you may select telephone to receive a dial-in number. To access a copy of the presenter's slides, please expand the handouts panel located to the right of your screen and select the PDF file. At the conclusion of today's presentation, we will have a Q&A session. However, you may submit your questions at any time by typing them into the questions panel also located to the right of your screen. I would like to welcome our guest presenter for today's webinar, Jonathan Wick, who's Principal of Revenue Cycle Management for Healthcare Solutions. Jonathan has over 20 years experience serving in acute care, insurance, and business solutions settings. As an active advocate of legislative changes to evolve the healthcare industry, Jonathan recently authored Healthcare Solutions, The Patient is the New Payer, and he's spoken at numerous national and state events. He's developed several nationally recognized programs in point-of-service collections, financial clearance, and operational best practices for hospitals. Jonathan is an officer on the Colorado HFMA Board, President of the Board of Directors at an assisted living facility in Boulder, Colorado, and Principal of Healthcare Strategy for TransUnion Healthcare. So, without further delay, I'll hand the call over to today's guest presenter. Jonathan, please go ahead.
Thanks, Nikki, and thanks to all of you that are on the phone today, taking time out of your busy days in the hospitals or healthcare space. I don't know about you, but time is an asset, and I don't have much of it left. So I'm happy that you can take some time today to hear about the patient and the new payer. What I want to do is talk about how positioning your revenue cycle can really help with patient financial engagement. I have a joke here to start. Okay, we'll call it a workaround until we're ready to hand patients estimates. I've got a patient here standing at check-in with a bag over their head. I don't know that the industry is quite that disabled, but nonetheless, presenting patient estimates to patients 100% of the time is a rarity in our industry. The best practicing hospitals I've seen are doing it in the 80 and 90% range, and I think the average is around the 30 to 40% range, and you're seeing collection rates in both of those cases in the low 50s at best. And so what that means is about half of the patients are coming through and may or may not have paid attention or even received an estimate and have a bag over their head, if you will, because until the envelope comes, it's kind of an afterthought. And what we're going to talk about today is how important it is to change that paradigm and really treat the patient as a payer, because they represent a large part of the spend and process now in terms of the rules and what money is coming out of their pocket from cost shifting. So as Nikki mentioned, I did write a book. It should be out on Amazon soon, and the profits of it will go to charity. We haven't picked a charity yet, but we'll look at it. But what I'm going to do is kind of go over some of the things that happened in revenue cycle when I served as a chief revenue officer, some of the things I'm seeing in my role here at TransUnion, and some of the other things that I see in HFMA as I serve on the board there, and just in the hospitals that I've seen from how we got to where we are as an industry, where we are now in revenue cycle, what's happening next, how the patient really is a new payer, and then I'll share some industry best practices for getting your revenue cycle into world-class performance. So how we got here. What you have in front of you is the very first physician fee schedule, believe it or not. In 1878, a group of physicians out of Virginia got together. Their names there at the bottom. It was about 12 of them, 12 of them, I believe. And they said, these are the fees that we're going to charge for stuff that we know how to do. Patients paid cash for a visit. As you can see here, it was about $1. Their service area was the Sinclair's Farm to William Booth Street to Mudwall and William Robinson's house. And then beyond these limits, it was 33 cents a mile. to go there, and then they had overage charges of $2. Below there, you can see consultations aren't that far off from today. $5 or $10 to go see a doc. There are some health plans out there, especially if you're one of our lovely legislators in the government. They still have what's called a 10-100 plan. They pay $10 to go see the doc. Most copays are around that range now, might be double that, but it wasn't that far off, almost over 100 years ago to have $5 and $10 copays. If you needed an amputation, which was quite common back then, it was $40, $20 for the arm. Fingers and toes were $5 apiece. Medicines, I love this. Pharmaceuticals are nowhere near this now, but if you needed to have pills, they're about 50 cents or 25 cents to 50 cents for a dozen of them, up to $1 if it was a powder. And syrups and tinctures and things like that, all these different diuretics and tonics, all ranged, in the pennies range, and certainly didn't have as many zeros behind them as they do these days in big pharma. Delivering babies was about $10 or multiples thereof, and it really was a cash on the barrel business. We'll walk through kind of how things have changed since then, but patients started as a payer is a point that I wanted to make, and then some dramatic changes happened in our industry in the United States. One of the first things that happened was the creation of the PAYER plan. In 1929, that plan was created. It was a group of physicians, again, that created a plan and provided inpatient hospital care at a flat rate for all services there. And then shortly behind, most people know this, Blue Cross began, and then finally Blue Shield in 1937. The uninsured rate before that was in the high 80 and 90% range, and that quickly brought it down to the 31% range. In 1965, we had CMS, or as I refer to it as HFMA when I started in the biz. The creation of Medicare and Medicaid started. That cut it again in half, and it pretty much stayed there for the most part. You saw it kind of go up and down with different things. SSDI and Medicaid brought it down to 11.5%, and then we saw a slow climb from 1978 all the way up until about 2006 when it reached its peak at 16.6% there. And that's when we had lots of things starting to hit the legislative floor from a legislative standpoint about we have the highest uninsured rate. People don't have access to care. It's too expensive. We need to get some affordability there. We need to expand Medicaid. We need exchange plans. We need to subsidize those premiums so people can afford them. And of course, we had our first enrollment period in 2014 with Obamacare. That dropped it down to 10.5%, and we're starting to see a slow incline to about 11.33% into this decade. Frankly, because patients are either not meeting the requirements under Medicaid, not meeting the exchange plan subsidies, or have kind of the flash in the pan has stopped. We're starting to see a slow creep in the uninsured rate. Up from the basement that we saw after the ACA rollout. So we'll see how that trends as we go. Commercial reimbursement significantly subsidizes the money from the government. The government, pays roughly 1-to-1 on most things. They have underpayments on others, but that kind of sets the base of most fee schedules in our country. Private insurance subsidizes that in the 120 to 130% range. Another way of looking at this is our country's got about half of it right now on Medicare and Medicaid. If you look over to the right here, about 50% of our country is either on Medicaid or Medicaid. If I go back to this other graph, that's paying a little less than cost for most of our hospitals. So the private payers, which make up about 32% of the market, are, and this is an AHA survey, are subsidizing that care at the 120 and 125% level. That's why I call it the $10 aspirin, if you will, or the $1,000 emergency room visit. As costs increase, there's a bunch of different factors that happen from technology, the baby boomers, or the silver tsunami, as I call it, other things, pharmaceuticals, stuff like that. But there also is just a payer mix that is slowly diluted over time to where you're getting government payments that are at or less than what the costs are to provide that care. And then you've got commercial insurance trying to keep premiums in check with deductibles, and that cost to collect has certainly detrimented a lot of hospitals and health systems these days. That's where we've been. Let's talk about where we're at. Right now, 17% of the gross domestic product is spent on healthcare. That is more than any other industrialized country by 5%. The closest one is our friends in France there, as you can see in this graph. That 17% is predicted to reach 20% by 2025. That will be more than anything else we spend on in our country. $1 in $5 is going to go to healthcare. I don't have an outcome slide, but we don't rank nearly as high on those. I would argue we rank closer to dead last. The book talks about how our outcomes in our country are very, very disparate from the investments that we put in them. And so it's just an interesting dynamic that we have such a large influx of cash into our system, but yet we aren't having the outcomes that we need. With that influx of cash, I like to follow the money. It's one of my mantras. About 20% of it went to prescription drugs, 22% of it went to drugs, 22% of it went to docs, 20% went to the ambulatory market and outpatient services, 16% went to inpatient services, 18% went to operating costs, and 3% went to margin. This is from AHIPs. This is what a typical insurance company spend comes from. There's other graphs out there that shows where all the dollars come from. But since a majority of our folks, 90% of the country, are insured, I felt this graph was interesting just to follow where that $3.2 trillion with a T, gang, goes every year. And that was in 2015. That number will be much, much higher in 2016, I fear. Some numbers to commit to memory. These come from Chapter 2, but half of American adults have one chronic disease, and 1 in 4 have 2 or more of these diseases, representing almost 90% of all healthcare costs. I'll say it again in case you missed it. Half of Americans have chronic disease, 1 in 4 have 2 or more of these conditions, and that's 90% of the cost. Those are very troubling numbers if you start wrapping your heads around that. That's a lot of folks that have a disease that is contributing to the cost of our healthcare. One would argue that some of that disease is genetic. Some may also point out that some of them may be lifestyle choices. Regardless, a focus on these diseases and the population health fee for value or value-based care movement is certainly, trying to tackle this the best they can. But 25% of our country has 2 of these, and 50% have at least one. Shines a lot of light on how we can start curbing some of the costs. You don't see a lot of legislation doing that necessarily. You see a lot of legislation talking about access and handling what types of plans and how they will pay, but there isn't a lot of cost utilization legislation out there yet. Those will be some tough decisions, I think, but this is the iceberg that we have to start chipping away at to get at really making healthcare affordable in our country and not spend $3.1 trillion. Another representation of that graph, my friends over at Kaiser Family, they reiterate that 50% represent 5%, or 5% of the population represent 50% of the cost, 20% of the population represent 82% of the cost. So there is a large skewing of the healthcare costs. They are not equally weighted across all folks that are coming into the system as a patient. There's a very, very isolated, narrow lane of folks that have certain conditions that represent the large spend that comes into our healthcare system. Believe it or not, people actually think they're healthier than they are. This is a study that was done by McKinsey. It's not meant to be an eye chart. I just want you to kind of focus on the colors here. So there's brown, orange, and yellow. Brown is someone who felt they are in excellent or very good shape. Orange is felt that they were in good shape, and yellow feels that they were in poor shape. Over here on the left, we have high risk and chronic disease patients who felt that 66% of them were in excellent or good shape, and for about 67% of them who had a chronic disease condition also felt they were in very good or excellent shape. And then finally, we have a bone mass index down here of patients who, by definition, are obese by the AMA and the AHA definition tables that are out there. They have a BMI of greater than 30, have a roughly 72% perspective on the positive impacts of their health. They feel they're in excellent or very good shape, or in fact they are recognized as obese by the BMI standard or stick. Agree or disagree with these numbers, the fact I'm trying to point out is, as the patients as a payer, we have patients that feel they are not part of the problem or the solution, depending on how you look at it, but they are representing a large amount of the cost. And until we start changing this paradigm as well, right now we've kind of got a free market for healthcare where you can purchase it, get access to it, even have the government help you out and do it, and have a very large spend. And there aren't any curbs on things like this to try to control some of that spend. as we proceed, and our hospitals and physicians are feeling the tightness of that as we try to deliver care in the best way we can. Most patients are worried about their healthcare costs. They may not be worried about their health, but they're worried about their costs. They are worried so much so that they're worried about affording them, very or somewhat worried. They're worried about losing their insurance, and they put those worries above, gun violence, terrorist attacks, losing jobs, or not paying mortgages. So that they rank it very, very high for the Kaiser Family Foundation. So it's just something to think about is people worry about their healthcare costs, but they're not really engaged in them, and we'll get to that in a minute. Consumers are very insulated from healthcare costs. I love this grid. It comes from Cooper and John. It's in the book as well. You have hospitals and docs over on the right, and the only thing the household or the consumer sees is this portion over here on the left. They pay their coinsurance and their co-payments. You could probably have another little line going up to insurance companies that says that they pay their premiums, but they pay a small part of that. Their employer typically represents the large lion's share, at least more than half of the insurance company premium, and the government certainly pays into that as well. But most households are very engaged on the part that comes out of their pocket, or the benefits that are applicable to them, the co-pays, the co-insurance, the deductible. That's what they're paying to the hospital and the doc. That's what they care about. The rest of these costs that we've been discussing thus far they've been somewhat blind to, unless they're a self-pay patient, and then they're very, very exposed to them as they come in. TransUnion did a survey. Compared to 1 year ago, how concerned are you about the following? Health insurance covers and what they pay, what amount I have to pay for that insurance, what my premium will look like, what my out-of-pocket costs will look like, and then finally the total costs. Very, very large disparity here. In the high 50s and 60% range, patients are extremely concerned about all of these things from a cost standpoint. Would receiving cost before procedure help you anticipate? Well, of course it would, and patients agreed. Almost 70% of them said, yeah, I absolutely want to know about costs before I come in. Transparency is something I'll talk about here in a minute. I call it the T word. It's an interesting thing that gets a lot of traction with legislation. It's a highly ineffective way of getting consumers and patients engaged in healthcare. Most of these transparency portals are out there, and patients just frankly aren't adopting them. They don't go and look at them. Some exceptions to that may be in the women and family services area, where you're an expectant mom, perhaps a hip or a knee surgery, but it's less than 10%, gang. There's a New England Journal of Medicine study out there. I'll show you another one here in a minute from, I believe, the Wall Street Journal, that talks through how patients don't look. They do what the doc says and they go, but they are worried about it and they want to know, but typically it's something that happens at the end of the revenue cycle, not something that happens at the beginning, and hospitals and providers, I think, can help engage that process a lot more and have through looking at that differently instead of through an envelope. When patients shop, they look at these things in the stack rank order. This is a study from EBRI. They look at drugs, of course. I think that's probably the most commonly used thing in all of our households. Most of us have a script of some sort sitting in our cabinet at home or on our counter. And I don't know that we look up the cost necessarily. We kind of go to Walgreens and indirectly look up, or CVS, or the pharmacy at our hospital if there's a retail one there, whichever one it is in your town. You may look. Lab or radiology is a close second. I think there's a lot of action there. Of course, with office visits, dentists will check. Outpatient surgeries, like I mentioned, also rank up there. Vision care for sure. Inpatient mental health, obviously those ones have a lot less traction to look because they tend to be surprises. Emergency didn't make the list because you didn't really plan for it, obviously. But prescription drugs and then independent diagnostic testing rank high in terms of where you need to check or where patients want to check for health plan costs. JAMA survey, I apologize, I thought it was Wall Street Journal. JAMA had a survey about why or when patients want to look for costs in advance. Compared to behaviors of consumers on high deductible plans or traditional plans, they actually wanted to look at that. So the whole preponderance of these high deductible plans was, hey, we're going to give patients deductibles. They're going to get engaged in their care. They're going to make smart choices like they do with anything else, with TVs, cars, apartments, golf clubs, trips to Hawaii, the grocery store, you name it. They're going to see prices and they're going to make decisions because they know that it's coming out of their deductible. Well, it didn't work. And there's studies out there that show that the deductibles are an ineffective way of directing patients to lower cost providers in their current form. JAMA reinforced this. There's a New England Journal of Medicine article out there that enforces that as well. There was only a 1% difference in a patient who had a high deductible plan versus a traditional commercial plan. And these they have shown to save money, but that savings has actually been a backfire effect. That savings that has came from high deductible health plans has been someone not even going at all, which any of us that have worked in a hospital know that's like the worst thing to do, is that you just get sicker and sicker and sicker, and then you're a train wreck that hits the emergency room, and things get really bad at that point. You don't go to the doc, you don't fill out your scripts, you don't do anything, and then you have multiple comorbid conditions, and you end up being in the ICU for a while, and that scares you. So lots of studies out there that show deductibles have lowered cost. Most of the time, that reduction in cost is a reduction in utilization, not by choice. So there's something to look up as you go. This is a detail from that study, and that 1% is there at the bottom. But you can kind of see there's very, very tight difference between a high deductible health plan and a non-high deductible health plan, and they're highly correlated over there to the right to differences in changing, and there aren't. And so just that 1% is there. Consider healthcare professionals compare costs across the different organizations. It just doesn't exist. Why don't they look? Well, most folks have insurance, right? And so they're like, well, I got insurance that's going to cover it. Some feel like they have a choice. They don't have a choice anyway. Doctor told me to go to Smith County. I'm going to Smith County. That's where he said to go, or she said to go. That's where I'm going to go. He wrote me a script for there. She wrote me a script for there. I don't feel I have a choice. That's another opportunity, I think, in our referral bases to say, hey, here's a script. Here's some places. Here are different choices from where you could go get this care. You see a lot of employers engaging at that step. It's script management, if you will, and you start seeing transparency come in a better form there to where, hey, your doctor wants this for you. Now let's talk about where to get it. It's even better if the doctor says, hey, this test is going to be about $10,000 or $4,000 or $1,000. Is that something you can afford? And if it is, great. If it's not, then let's talk about what kind of charity or financial counseling plans we can get, because they wouldn't have ordered it if you didn't need it. But not having a conversation at all certainly sets patients up for a poor financial experience and very, very high bad debt risks, which we'll see in a minute here with hospitals. Finding information about costs is also very difficult. You see that there at 21%. I'm not concerned about it. God bless the 12% that aren't concerned, because it's $3.1 trillion. And so I think they get concerned when the bill comes. And then I don't want to ask my doctor about costs. Those are patients that probably just are, really scared of new diagnosis and things like that. But these are some reasons why, from periundum, that there's some patients aren't really shopping for care necessarily as they get things ordered for them and access the system. That was a whirlwind tour of where we are now. Let's talk about what I'm sure everybody wants to hear about. Where are we going? American sentiment on healthcare insurance, individuals or government responsibility. Gallup does this survey. Again, not meant to be an eye chart, but something to think about here is the light green line is the government should cover healthcare. And it says all Americans. So that could be single payer. That could be expanding Medicaid and Medicare to everybody, and that they would take full responsibility for figuring that out. One would argue over the last 10 years they've gotten more into that camp and have provided things like the Medicaid expansion and health benefit exchanges, and you can see the impact of that as it dropped down through those years. But it recently has switched back the other way to government responsibility as late as 2016. The lower dark hunter green line is the no. I just find it interesting that these things kind of intertwine depending on what type of legislative climate that we're in and what kind of economic climate that we're in. But right now, I would call it a 50-50 split, that half of Americans feel that it's the government's responsibility and half don't. What's important from this graph is to understand that a lot of Americans don't feel it's the government's responsibility. There's not this huge, 75 to 25%, lopsided argument that says the government should fund all of our health care. And I think taxpayers and things like that probably carry that weight where they are. There are a lot of Americans that are very happy with the health insurance that they have or have used it. They may not be happy with it, but they don't want any disruption to it because it benefits them. And on the other side of that coin, there are a lot of Americans that don't have access to the care, can't afford the care, and sit on one end of those spectrums of either being on the needy side or the elderly side, and the government's there to fix them. But needless to say, the spectrum is certainly widened in the gap since 2008 to now, and there's not much disparity. And we're starting to see a similar position on opinion here instead of having that lopsidedness we had 20 years ago. Nothing around here. Repeal, boy, we saw that goat rodeo go over from the spring to now. I did several talks on ACA. Feel free to reach out to me after this call and get with me if you want to hear my perspective on some of those. I didn't have time in this deck to get to it. We saw repeal and replace start, then we saw repeal and retain happen. We saw the American Health Care Act or Reconciliation Act come, the ACHRA. Or AHCA, sorry. We had the Better Care Reconciliation Act, the BCRA, the Senate's version come. This is a great poll from NBC News. All people think it's a good idea. 16% of all people think it's a good idea to repeal the ACA. About half of them think it's a very bad idea. And if you ask a Democrat, they think that 73% of them think it's a bad idea, and 17% of the Republicans think it's a bad idea, and so on and so forth. What's interesting is that there isn't much agreement on whether it's a good or a bad idea, and it's very party focused. But I think what we're starting to understand from our legislation is that healthcare in our country is complex. The reimbursement and delivery is complex, and it's not easy to touch. And so you can't just take out a bill that's covering 30 million people or change a subsidy package and a tax code by vote without having some constituents really get alignment as to how that's going to look. And every time a CBO projection comes out, I feel bad for those guys in the Congressional Budget Office. I feel bad for them because they have to look at that paper and understand, what that looks like from a impact to the citizens if that bill were to pass. And part of that impact is outlined here. This is a CBO report that was done on the first iteration of the bill. This shows what the uninsured rate would have drifted to had that bill passed. It would have gone to uninsured rates beyond those that I showed you at the very beginning of this slide deck, up into the high 19 to 20% range. Under the ACA, they would have, of course, stayed flat. And then you would have seen $839 billion with a B dollar cuts to the Medicaid program across our country from 2017 to 2026. I don't think that was the intention of any of the ACA repeal plans, but that's what the CBO said. And so as far as, what everybody wanted, the bills talked about how it was going to work, but the impacts were projected. And this is why you haven't seen much traction on the Hill and in Washington and not much collaboration, because this, frankly, would disrupt healthcare so much that none of them would get revoted in, and you'd have a lot of revolt and things happening in these states. And so as legislation tries to disrupt where we're going over the next few years, I don't think we'll see another piece of legislation this year. They tried 5 times by my count and failed. And so I don't think it's going to happen before tax code, gun reform, some of this immigration stuff we're seeing, international trade and things like that. I've heard from McConnell and some of the other folks, Mr. Ryan, that they're going to move on to other stuff. And they may come back and try to stabilize the exchanges if they can, but this is where we're at. Benefit exchanges. This is a great graph from Kaiser Family. The light baby blue represents the number of exchange plan choices for Americans. The navy blue represents 2, and the orange represents 1. So in 2016, 85% of the exchange enrollees had a choice of 3 insurers. That dropped to 57% this year. We had 12% in 2016. That has almost doubled to 22%. And so you see a lot more reductions happening in terms of choice. And then you also saw a dramatic increase of where there were only 2% of the enrollees had a choice of 1, and now there are 21%. So you're seeing this dramatic change to where if the exchanges don't get stabilized soon, there's frankly not going to be choice. Carriers are exiting, and those that have stayed are doing okay. You saw the MLR here from Kaiser Family drop from 88% to 75%. Those of you who haven't tracked this much, a medical loss ratio, frankly, is just what are all the premiums minus all the costs that are coming in to deliver or administer that plan and pay those claims. Carriers like that range to be, as high as it possibly can be, or as low as it possibly can be. Sorry. And would love to, have an MLR in the 50s or 40% range. But it fast approached the 88 and 86% range when the actuaries first came out, and you saw a massive exodus of exchange plans happen, starting to stabilize here in the 75% range. They're making money at it. Those that have stayed as well, they're making about $45 to $40 per member per month. That number has gotten into the $99 per month range. And so I think you're starting to see some stabilization as of Q1 of this year. We'll see if that stays. I hope the legislation that they're talking about now with Lamar Alexander and some of the others on the Hill will continue to do that. They're looking at changing the SGR and some of the other things, or the CGR, sorry, for the subsidies and how those rates look in terms of just making these plans more attractive and more affordable and also more offerable to the insurance market. These are the exchange plans for this year, for 2017. The average deductible now, gang, commercially is about $2,000. You'll notice these are all in excess of that, except for the Cadillac plans, if you will, the gold platinums there on the far right. Bronze and silver plans have a $6,100 and $3,600 deductible, respectively. That is a lot of money for someone to try to meet before their benefits kick in. And they also have had a 20 and 23% increase, respectively, over the time that they were first introduced. So you can kind of see that in the graph over to the right. I thought it would be interesting to track the deductible increase by plan type. So another thing to take away from this graph is the folks that most need insurance that can least afford it have had the highest increase in their deductible. And so it's very counterintuitive. This, frankly, won't be sustainable as the ACAs continue. I have detrimental fears for the exchange plans and these ACA plans unless something happens, because, frankly, these high deductible plans and the MLR things that we're starting to see from some of the carriers and some of the county exits are just painting a picture of exchange plan doom, for me at least. We'll see what happens over the rest of the summer here, but I think the writing's on the wall based off some of these graphs. Deductibles, as I mentioned, are rising. They've gone up 63%. That's outpacing inflation and earnings by 6 and 11%. Would have been nice if we all got a raise, but we only got about 11% during this time, and increases in deductibles were fivefold to that. The average deductible, as I mentioned, is running around $2,000, and 83% of the workforce, gang, has a deductible now. 83%. So that's the majority of the patients that folks are seeing. They've got some sort of deductible in place, and they're having to spend on that dollar before they get premiums kicked in. Another graph just to kind of show that information, not meant to be an eye chart, focus on the colors. This is from 1988. I've been speaking for a while, and I kind of track this every year, and I love it. Kaiser puts this out. It shows the enrollment by plan type, and something that's interesting is we've seen a dramatic decrease in the conventional indemnity HMO plans. They represented 60 to 70% of the market just 20 years ago, and that has dramatically shifted the other way now to these high deductible, point of service, self-directed, self-offered plans where they have very high deductibles, and we're seeing a proliferation of that in the market, and it's just completely shifted over to the right side of this graph, and that is the new paradigm for health insurance coverage, is cost shifting to the patient. So talking about cost shifting, let's talk about how the patient is a new payer. In 2002, they represented about 10% of the payments coming into a hospital. So if you billed a claim to an insurer, they would pay about 10 grand or 9 grand of it, and the patient would have about $1,000 of out-of-pocket cost. That number has since transitioned to 30%. This is a study from MGMA and Instamed. And so that's significant, gang. That's tripled. And so now that $1,000 has turned into $3,000, or a better example might be that $100 has turned into $300. And that really does start to change the paradigm in terms of if you're getting a third of your money from a patient, and are you treating them as you treat a payer and setting up ways to make yourselves get paid easy, like lock boxes and payment mechanisms, and are you negotiating rates before they come in? A lot of those things don't happen, and a lot of revenue cycles I'm seeing are still relying on traditional paper-based billing, and they're feeling the pain of it with rising balance after insurance and patient liabilities as they go. Deductibles cause confusion, medical debt, and they rarely direct behavior. I alluded to this earlier. This is a great quote from Becker's. They said, research shows that while shifting responsibility to consumers works out well for employers and cost shifting, it leads to financial troubles for consumers and hospitals when patients who don't understand their plans end up facing a bill that they cannot pay. Moody's agrees. They say today's high deductibles are tomorrow's bad debt. I read something the other day that said Moody's may shift if some of these bills pass, which they didn't quite yet, but they're still talking through some of them. It may be next year, but Moody's had its guns locked and loaded to move hospitals' bond ratings and stocks from stable back to neutral if some of these bills were to pass just because of some of that legislation that I had shown you. They've identified a risk that consumers covered by the most popular insurance plans will be unable to meet those needs, and growth in commercial insurance is something that frankly is very difficult to do these days, particularly where there's services and deductibles. I encourage all of you listening to look at where your cash is coming from with a microscope and understand that reimbursement from the insurance and that reimbursement from the patient, because I'm sure they've dramatically shifted in the last decade. Stop making things compulsively worse. Cost sharing under most plans exceed resources most families have had on hand. The Federal Reserve that found that just a little under half of Americans would be able to cover an expense costing $400. Those of you that work in hospitals know that would cover the gown and walking through the door in most places, maybe an x-ray or a mammogram. But if you're there and you're in a bed, you're going to easily blow $400 out of the water in the emergency room, in the surgery department, in the high-cost imaging areas. And that means that is risk and debt to you if a conversation isn't happening. I did a fun exercise in case, just to show you how far $500 or $400 would go. You can go to healthcarebluebook.com. It's kind of a fun website. Type in your zip code and punch up some common procedures. I just picked some randomly here for my zip code. I picked a doc's visit, a CAT scan, an ED visit, a vaginal birth, an appendectomy, and a hip replacement. That was the cost. That came across on there, and then I worked for an insurance company, so I put some standard plans that you think you might see today out there. So you may have a $25 copay to go see the doc, or you're not underwater there. But as we go down this path, you got your CAT scan, and you have a $1,500 deductible, which is pretty average these days. You've got $828 out of pocket, which means if you had $400 to pay it for that slide I just showed you, you're $428. You guys can read the rest. You get down to this hip replacement, you're talking $7,000, gang, because you typically hit a co-insurance level with your deductible when it comes to these surgeries and sometimes an inpatient stay. So you may have $7,400 that's due to you from the patient, and they can only afford $400 of that in their bank account because they're on a fixed income. So it's something to think about as you proceed. As patients endure this onboarding to the system and consider the costs as they go, they have received lower credit ratings, used up all of their savings, took on debt, took out a mortgage, and had to declare bankruptcy. And one of these times I'd love to say that the number one cause of bankruptcy is not medical bills. Today's not the day. It still is. And so medical bills still represent the number one form, and you see it here. Another interesting fact here with these graphs is you'll notice that the blue are insured patients and the orange are underinsured patients. So, and there's not much disparity between that underinsured and the uninsured, which are in that kind of dirt red color. Very tight disparity. Actually, some of them are even higher. Some of these patients would have had insurance, but with a high deductible, and had to take on more debt than someone that had no insurance at all because they weren't able to take advantage of some of the charity and discounting programs at the hospitals. So something to think about. TransUnion ran a report, and this is a report that's showing the percent of patients not paying a bill in full. 68% of them in 2016 did not pay a bill that was $500. That number is 85% for $1,000, 89% for $1,500, and 99% for a bill that's $3,000 or more. A patient did not pay in full. That trend, frankly, is not sustainable either. I have the details of this report if you'd like to see it, but it's just a scary, scary time as you see these numbers go up as patients are just getting into more and more trends of unaffordability as they proceed. Propensity to pay by deductible size. This is another graph for you. So as you see the amounts increase, the likelihood of you as an entity collecting that money goes down significantly. You have a 68% chance of collecting all of the amount of a patient who owes you under $1,000. You have a 62% if it's under 2,000, 61 for 35, so on and so forth. You get all the way up to the other side there. And JP Morgan ran this. They said as patient payments increase, the ability to optimize collections and drive payments early in their process will take on great importance. So it's very important to treat that patient as a payer. Why? Because they don't pay you. Costs are high, much higher from a patient than they are from collecting from an insurer. Medicare, whether you like their reimbursement or not, they're a pretty good payer. They pay their bills pretty regularly. They were one of my favorites, at least. I at least knew they were going to pay me, and they paid me on time. Patients pay twice as slowly as commercial payers do, and it may cost you 3 times as much to get after that money. So as patients owe a third of that amount, your cost to collect can go up. $1 today is worth a nickel in a year because, frankly, the time, energy, and resources in terms of your dunning cycle, statement costs, call centers, collections costs to third parties, it dramatically diminishes once you get in to the 100-plus day mark. And pretty soon it's an even wash, and most hospitals are writing it off once it gets out there because it's frankly not collectible. So getting that money today is the best. One of my mantras is the cheapest time to collect money is right now, today. It gets expensive tomorrow and even more expensive next month, and it's ridiculously expensive in a month from now, so or 2 months from now. So it's important to have your cheapest cost to collect be optimized and do it today. Why are patients struggling? Well, they can't afford it. That's kind of a duh. 1 in 4 Americans have an unpaid bill. 1 in 5 are paying it over time, and 1 in 10 will never pay it. And I've mentioned the bankruptcy piece. It's hard to pay a hospital. When I was running a revenue cycle, I had patients, waiving their credit cards or a lot of bills, believe it or not. Hey, I'm ready to pay you. It's hard to have that on-site payment without a pre-service estimate right there that you can kind of guarantee. Because if the number changed, they're calling you back. I already paid you. I'm not paying you more is the answer you get. So it's hard to pay a hospital right now. And that's why I think some patients struggle to pay it because they were ready at one point and then they weren't later. Bills aren't easy to read. We all know that. 53% of patients need clarification per a Navicure study. And you're seeing a lot of patient-friendly billing stuff come out of HFMA to help with this. And there's a lack of price transparency. A Navicure study said that 42% of healthcare organizations offer cost estimates, leaving many patients stunned. There's about 58% or so that can't offer those as they go. Consumers prioritize paying their bills much lower. Medical bills rank on this list as number 7, 3 up from the bottom. It comes behind rent, mortgage, credit cards, loans, and leases. They stick them down at the bottom. We've all done it. It comes, so I'm waiting for everybody to bill me, and it sits there until the one with the big red giant 50 font says, we're going to take something away that's valuable to you unless you pay, then we pay it. And so until that paradigm changes per McKinsey, we're going to be in big trouble too, because healthcare bills, frankly, just don't carry the amount of weight and mustard as others. There are 3 types of patients here: the ones that pay you, the ones that need help paying you over time, and the ones that want or may not pay you either because they won't or can't. And that last category is the one that I really want to talk about. Providers are calculating propensity to pay whether our patient's insured or not. If anything from today, it's important to understand that a patient is a payer, be them self-pay or if they have a high deductible. And it's important to kind of look at what their likelihood of payment is and differentiating between willingness and ability. High pre-service balances are key areas to focus. Transactions like credit score, mortgage balance inquiries, address verifications, and others can help determine whether a patient can pay you, get them eligible for charity. Treating them like a payer, just like you would an insurance company, pre-negotiating those payments and establishing a payment mechanism is huge. Your traditional revenue cycle has had healthcare service shoplifting, I like to call it. Hey, I'm coming in, I'm getting a bunch of stuff, I don't care how much it costs, I'm leaving, bill me later, and then you have to bird dog and track that money down. Statements are on a 90 to 120-day cycle, downstream billing, bad debt risk, slow payment by snail mail, and acquired payments. Today's revenue cycle is innovative. It's requiring patient financial clearance, employer and plan education, pre-service estimates, credit scores, pre-established payment plans, point-of-service collections, consolidated bills, guarantor balance. That's getting a lot of traction right now. Hey, you owe us $10,000 since the last time you were here. How would you like to pay it today? Retail, transparency, consumerism, we've all heard those terms, mobile payments, bad debt segmentation, and others. So it's important to capitalize on every one of these entry points before they come in, when they're getting scheduled, when they're getting pre-reg, and when they're getting discharged. Once they leave, here's your snowball. I mean, it's really hard to get that money, and you saw that in some of the graphs I've shown you. You guys will have a copy of this deck, so I'll go through some of these quickly because I want to save some time for questions. But basically, these 4 buckets here at the bottom are your safety nets, right? Is the patient eligible for something? Insurance, a charity program. Can you verify that eligibility for the benefits that they're getting today? Can you estimate what their cost is going to be, either from a self-pay discount, a sliding scale discount, or a estimate based off their insurance benefits and the deductible remaining and things like that. And then the last one is are you going to get it? Are you going to get it before they come in, when they come in, while they're there, or after they leave, or well after they leave, or not at all? And you need these gates in place to understand each one of these steps in terms of how their benefits are there and what you're going to do. You can stratify the benefits here. You can ask for payment. You could see if you got it or not, and if you're done, great. If not, you can run credit on them. And you really want to get patients into these stratifications. This is from a best practicing hospital on the West Coast, and they stratify a large percentage of their scheduled elective patients into these buckets and really understand financially what type of patients coming through so they can have those conversations and financially engage them as they appear. Well, if I haven't thoroughly depressed you, I think there is hope. If we can figure out this Venn diagram together, I think we'd be okay. But if the provider, the payer, and the government and the employer start doing things for the patient instead of themselves from a profitability, regulatory, incentive program, those types of things may change. If not, we're going to continue to have divergent and very, very erratic healthcare delivered in our country from a cost, utilization, coverage, and a growth standpoint. I believe that's it, and I'll open it up for questions. I'll leave my contact information up here. You could send me an email if you liked what you saw or want to figure out how to get a book. But feel free to ask me some questions if you have any, and I'll turn it back over to Nikki.
Thank you so much, Jonathan. What a very engaging presentation. Before I take our first question, just want to remind everyone to type their questions into the questions chat panel located to the right of your screen, and we'll take as many as time will allow. I will go ahead and address one question about accessing the replay. After this call, you should receive an email from the HFMA chapter with access to the full replay as well as the slides if someone else would like to obtain a copy who did not participate in today's webinar. All right, so let's go ahead and jump right in. The first question is, where do you see the most impact to revenue cycle now?
I see it primarily happening on the back. I think patients are really, really frustrated with the bill. You saw on some of the slide deck, that there's little, if any, engagement on the front. And I don't think that's to blame on any entity. I think it's an industry issue for us to tackle, not necessarily a patient or a provider or an insurer or an employer issue. But just because of how the system's evolved and is set up, having the front be the mechanism has been very difficult for us. And I think if you could fix that, and I know it's cliche, fix the stuff on the front so the back's better, but imagine, if you will, having a patient understand all their costs as they're coming in and their benefits, and there were resources to support it regardless of where they were coming from, or there were tools and technology to do so. My son had a thing on his leg, real quick story. I went to the doctor to get it looked at in a little clinic. The doc at the end said, yeah, I'm going to get you the cream, to put on it. Do you have insurance, was a question she had asked. And I said, well, that's an interesting question. What if I were to say no? And she goes, well, I've got some vouchers for you to get it, because I want to make sure your son gets it. And I go, okay, well, I do have insurance. She goes, great, if it covers this or not. And I said, yeah, I believe it does. She goes, well, if it doesn't, come back and see me, but I want you to be able to afford the care you're giving. It's an example of how the paradigm can kind of change. The book talks about that a little bit, to where, that was 10 seconds that I just talked to you about. You never want it to disrupt the patient-physician relationship, but having that coupling of the finance happen in collaboration with the clinical delivery would certainly help. And I think the back's getting impacted by that now. There's just a lot of frustration and things. And if you had these conversations up front, you'd have a much better day for the patient and payer, provider, patient, and payer.
Great. All right, thank you for that. I am trying to sort through here. Here is a question from Holly. She asks, on average, what percentage increase have you seen in bad debt? Or what percentage of gross patient revenues are you seeing in bad debt?
Yeah, I'm an HBI guy, so I'll plug them a little bit, Health Business Insights. They have a dashboard. I don't have it in front of me, but I was watching I watched that very close, the percent of bad debt. It is climbing. I remember the days when I started in healthcare, it was running in the 10s and 11 at our hospital, and then, we were very, very happy when we saw things like Medicaid expansion and other initiatives, including our point-of-service collections program, bring it down into the 7 and 8% range. I think a lot of hospitals saw that, but they're starting to see it creep back up again. TransUnion did do a survey, Holly, and I can send it to you on another WebEx where we surveyed the team and said, hey, have you seen a balance after insurance increase? And 78% of them said they did in the last 5 years. And so they're seeing a huge increase in this balance after insurance that's owed to patients. That indirectly impacts your AR days, which are also climbing in the industry. Those are going up dramatically too. It used to be okay to be in the 45, 50 range, and now you're seeing hospitals in the 55, 60 day range. And like, what the heck happened? Well, you have to collect from a patient now because they're 30% of the cost. Our NPR from a point-of-service collections program at our hospital, HFMA uses a 1.5%, 2% range. I think NAHAM does that as well. You should see a tenth or a half or 100, change in that. It just depends on how much you're going to engage those patients in terms of streamlining that. Theoretically, it could increase 30%, right? Am I going to say it's going to increase 30%? Not, but that a large percentage of your patients owe you money, and your net revenue as a function of coming from the payer and the patient, if you focus on that patient part, would increase, and I would argue it would increase by hundreds of thousands to even millions in some organizations. Our hospital collected $4.5 million a year up front. We were not a super huge hospital, but we were doing it, and I've seen other hospitals like Banner's a great example. They're collecting $90 million in a year, and they collect from 95% of their patients because they just lived it, and you could bet that impacted their net patient revenue. So I hope I answered your question.
Very thorough. Yes, definitely. Thank you for that. All right, this next one, a bit detailed, so bear with me here. It comes from James, and he says, we are currently pushing front-end collections. We're now getting a lot of pressure from department heads and even up to the board concerned about lowering survey scores and satisfaction by asking for money. I always say the bill is coming regardless. But what have you seen as the best way to educate non-finance people to the need about this? Any insight?
Yeah, man, I probably get this, I'd say 90% of the time I talk. So kudos to you first. They're going to get the bill anyway. So would you rather have the poor satisfaction score later or have us try to do something about it now would be my first answer. The patient access or revenue cycles, first and last impressions are with a registrar and a biller, right? Hi, how are you? Welcome to our hospital. Can I see your ID and insurance? And then here's your bill. And typically there's not someone saying, here's your bill. It comes in the mail, and then you hear this, what the heck is this? And so if there isn't anything between that dash or hyphen, if you will, you're going to get it. Clinical departments and department heads in a hospital need to see the numbers. I've ran debt reports by department. Those are compelling. Hey, here's how much money we billed out the door for like an emergency department. Here's how much went to bad debt. Here's how much we billed out in imaging or an x-ray. Here's how much went to bad debt. Here's how much we billed out in surgery. Here's how much went to bad debt. And oh, by the way, here's how much it took us to collect that money downstream. And believe it or not, most patients, there's a McKinsey survey out there that I can get you, Jane, if you want it, that talks about most patients want to know. I bet everybody on their phone is going to nod right now. You all want to know what it's going to cost before you have it. You want to know. Whether you can pay it or not is another discussion, but you want to know. You may not want to know at a certain time, but you're going to want to know before an envelope comes, 2 or 3 weeks later, right? And so hospitals are set up to want to engage patients and inform and educate them about everything to get better and get well. But the finance side has always been kind of this sacred cow that you can't touch. And that culture of collections really needs to come around. So I've got some slide decks and things too, if you need to see them, that talk through that culture of collections and creating it with those department heads And starting in an area like imaging is a great place because those are snapshot care. The estimates are pretty close in that area. There's a lot of patient volume. You can kind of focus and you can kind of test it out there. And then, you really need to have your CFO, your board, your CEO, the department heads, everyone drumming to the same beat because, man, it dies a miserable death if everybody's not following that culture.
Great insight. Thank you for that, Jonathan. I think let's go ahead and take this question from Joe. He starts off really saying kudos for great information in your presentation. He wants to know what trends are you seeing in terms of combined physician and hospital back-end offices? Have clients been successful in integrating both, or due to the differences in both, are clients continuing to keep the billing and collection efforts separate? So he was hoping maybe you can highlight some specific departments or functions where clients have been successful with this type of integration.
Yeah, I think consolidated billing is where I'd start. I think patients want one bill, and I think if you can get that, I don't know that you need to have Epic to do that, by the way, but I think there's ways of getting at coming up with agreements with bundled payments, not the ones that Medicare is inflicting, but a bundled reimbursement, if you will. There's ways to run estimates. You can run an estimate on it that's called a combined estimate. That's something TransUnion's wheelhouse. You can have an estimate that looks at both the provider and the physician or the facility and the physician and put them together. I do think that helps from a billing and collection standpoint because the patient's seeing one invoice, if you will. I'm not going to call it a bill purposefully like they do with everything else that they pay. They're not seeing, like I used to tell patients when they came in for a surgery, you're going to see 3, maybe 4 bills from us. And I hated saying it, but it was the truth. You're going to see one from us, one from the doc, one from the anesthesiologist, and maybe one from a radiologist or a pathologist or something. Those 4 bills are going to come. The next question I'd get from the patient is, well, how come you guys can't put them in one? They don't get that, and I think that's a huge lane to be in. And I am seeing customers and clients become very, very effective at figuring that out. They have to be patient. They have to kind of have those contracts and own them. Owning the docs helps and figuring that out. But I do see that as a future thing is that, especially the millennial population, are going to demand one encounter, one payment, and one bill. It's unfortunate that the industry isn't set up to reimburse that way, but try to treat it like a self-pay patient, figure it out through that stream. I think you'll see that. I think if you look at all the overhead that's on the back end of a revenue cycle from a prior authorization standpoint, a medical necessity standpoint, a claim status standpoint, a lockbox and billing standpoint, there's lots of things that can be optimized and streamlined by combining those functions because there's a lot of duplicity and triplicity, if you will, because those things are disconjointed and bad, and you really need to see some collaboration there. And I do think it's moving, and I think it's a wise direction to go in.
All right, thank you for that. A lot of great information shared today. As we wrap up our Q&A, I do want to just take this time to thank the HFMA members and the healthcare community for joining the call. As we end today's webinar, you will be automatically routed to a survey, and we just ask that you participate in those very brief questions. We would love to know what other topics you'd like to see in webinars such as this, and if there are others in the room who viewed with you, be sure to share their email address as we want everyone to receive credit for today's event. I'd also like to invite you to join us for our next webinar, which is scheduled September 12th, and the topic will be Health System Success Strategies under Alternative Payment Models. And if you'd like to learn more about this and other upcoming events, feel free to visit their website at hfma-co.org. So thank you again to our guest speaker, Jonathan Wick of Healthcare Solutions. Just a plethora of great, timely information shared with our audience today. So Jonathan, thank you again on behalf of HFMA for joining us today.
No worries. It was my pleasure. Have a great day, guys. Make positive change.
Love it. Have a great afternoon, everyone.